Today we're covering pulmonary disorders, obstructive and restrictive. Now again, we've cut out the preparation content, we've cut out the A&P review. So it is on you to do those prep questions before or after the exam. At this point it's after the exam, to understand the underlying anatomy that we're going to be using to discuss today. After that, we're going to move into fluid and electrolyte homeostasis and imbalances, along with acid-base homeostasis and imbalances. That's going to transition us into kidneys next week. The reason that we go from respiratory to renal is very specifically their relationship to these imbalances. You'll see what that is as we start to cover it. So we'll just start with our lung disorders. Alterations in pulmonary function. As you know, our purpose of our lungs is to participate in gas exchange, right? We're going to get oxygen from the atmosphere. We're going to off-gas carbon dioxide. If we have any physical problem with the lungs, that's going to be compromised. If we have any issue with the respiratory membrane, that's going to become an issue. So there's actually going to be several ways in which the lungs can become compromised. Just having a physical obstruction is a big category, and then having restricted movement of the lungs is a very big category. So obstructive versus restrictive pulmonary disorders. Hypoventilation. As I started covering in A&P2, when we breathe less for any reason, maybe you took a drug and the side effect of that drug is hypoventilation, and maybe your dose was a bit too high. Maybe there's some other reason for hypoventilation, like a neurological disorder or autoimmune disorder. Regardless of the cause of hypoventilation, the outcome is insufficient oxygen and also insufficient off-gassing of carbon dioxide, right? So I want you to start thinking of carbon dioxide and getting rid of it as just as important as getting oxygen. We know the mechanisms of ischemia, right? We know not getting oxygen and nutrients is going to lead to a failure of ATP pumps, which is going to lead to hydropic swelling, lactic acidosis, et cetera, et cetera. So that's important, but many cells have a store of ATP, and they can go a little while. What happens when your partial pressure of CO2 goes up? Carbon dioxide. This is what this means right here, partial pressure of carbon dioxide. Your pH goes down. Yeah, and that's why this is going to take us to those acid-base disorders. So when your carbon dioxide is bubbling through water or whatever's in your plasma, CO2 plus H2O, does anybody remember what that product is? Not sodium bicarb is on this pathway, but it's not, or not sodium bicarb, bicarbonate, sorry, is on this pathway. H2O plus CO2. What happens when you bubble CO2 through water? What's that? CO2 is carbon dioxide. Which is what? H2CO3, which is carbonic acid. Yeah, we do not like acid in our blood vessels, is one thing we're going to learn today. And that's going to be called respiratory acidosis, but that comes later. Hyperventilation, again, we're considering not just oxygen concentration, but also carbon dioxide level. In hyperventilation, we off-gas carbon dioxide at a higher rate. And then what happens to pH? It goes up, which means alkaline or basic, depending on the age in which you were taught chemistry, which is going to be called respiratory alkalosis. And again, there can be multiple causes of hyperventilation, as simple as anxiety. Maybe you just took a really hard test. Maybe you're at really high altitude and the oxygen level is low. Maybe you have a brainstem injury or an obstructive or restrictive lung disease. Respiratory alkalosis, A-L-K-A, alkalosis, L-O-S-I-S. Okay, now there's a slight difference between a lack of oxygen in tissues and a lack of oxygen in the blood. Hypoxemia just means there's low arterial oxygen and low hemoglobin saturation. Hypoxia is simply tissue oxygenation. So you remember you can have your oxygen in your bloodstream can be fine, your tissue, a localized tissue, maybe not be getting oxygen for some reason. Slightly different thing. And I love this terminology, hypoxic hypoxia. You have low oxygen because there's low oxygen. Surprise! High altitude here in Denver, Colorado, we've got slightly hypoxic hypoxia going on all the time. Anemic hypoxia, if you are anemic, your red blood cell count is low, your hemoglobin count is low. Therefore, the oxygen level in the atmosphere is fine, but it's not in your red blood cells or there aren't enough of them. Circulatory hypoxia, something's happened to your heart or your distribution, just like all of those pathogenesis of shock things that we did in the first unit. Astotoxic hypoxia, there's a toxic substances that is impacting your ability to circulate oxygen. Now again, when I mentioned these exams are not cumulative, they are not cumulative, but we're still seeing the exact same physiology we saw in Unit 1 playing a role in Unit 2, and that's going to continue to be true. We're just going to talk about the physiology less and less, and we'll start talking more and more about specific diseases that are categorized as physiologies we've already seen. Like we'll see a lot of inflammatory disorders, neoplastic disorders, genetic disorders, and so on. One sign of long-term hypoxia is clubbing of the fingers. So the mechanism is a little poorly understood. Our best guess is that if you have systemic low oxygen for a very long time, your microvascular may change to compensate, and that will be very particularly visible under the nail bed. So when we do our clubbing of the fingers test, when you put your two index fingers together, there should be a space between them. You should be able to look through that space. I can see you, right? Clubbing of the fingers means when you put those back to back, there's no space at the nail beds. And that just indicates, again, microvascular changes. Yes?
Is there some sort of link between having nails that are shaped that way and having better circulation?
What do you mean, having, if you have clubbed fingers or if you have the normal?
Does clubbing...
Clubbing is a pathology. Clubbing is something's wrong.
Okay.
And it's compensating. It's probably not doing a great job.
Okay. I was trying to think of like, if that compensation results in something.
It results in some improvement. Not that we found. Again, this is poorly understood. We're just working on a best guess here. It's like why, I don't know of any like systemic studies for do they have improved capillary beds all over? Is there like some better oxygen delivery everywhere else?
Seems like it would be hard to measure.
It is, yeah, it's hard to measure in a living person anyway. Again, I don't necessarily know. I could look those up too. All right, ventilation perfusion matching. Now, does everybody remember ventilation perfusion matching? What do I mean by ventilation perfusion matching? Yeah. So, okay, if you have a poorly ventilated alveolus, there's a capillary bed around that alveolus. Do we want that capillary bed to be partially perfused, fully perfused, not perfused, poorly perfused? We want it to match. If it's poorly ventilated, we want poorly perfused. What happens if it was very well perfused but poorly ventilated? Or do what? Yeah, you're retaining your CO2, you're not oxygenating, so some of the blood that makes it to the left side of your heart is not going to be fully oxygenated. You're going to have mixed oxygenated, deoxygenated blood going out to your systemic circulation. All of this terminology should be familiar. You should already own it. Okay, if you have a very well perfused alveolus, what do we want in terms of, ventilated alveolus, what do we want in terms of perfusion? Lots of perfusion. We want it to match. What would happen if it was well ventilated but poorly perfused? Yeah, you're not really meeting your ability to oxygenate. So less blood is going to move forward to the left side of your heart. So let's illustrate. Here's a poorly ventilated alveolus. Here's very well ventilated alveolus. Here's a poorly ventilated alveolus with an abundant capillary bed. Is that getting oxygenated? No, so deoxygenated blood goes back to the lungs, right? Whereas here is a capillary bed that is not perfused around a very well ventilated alveolus. And are you getting any blood from that? Nope. You just haven't met your capabilities. So a lot of things can cause these situations. This is just something we're going to refer back to. Atelectasis, does anybody know what atelectasis is? Should. So what is it? Collapse. Lung. Yeah, so it's a complete or partial collapse of a lung or a section or lobe of a lung is really how we're going to use it in here anyway. So atelectasis would be like partial, right? As opposed to something like pneumothorax, which would be like complete lung collapse. Okay, pneumonia. Let's see, adult respiratory distress. Andrew, do you have a question? Yeah. Yep. And that is in your notes, by the way, for this slide. I have a little cheat sheet that I'm looking at, basically. Probably, yeah. Yeah. In all likelihood, yeah, it's on one of the things that I've given you to study. Pneumonia, ARDS, normal ventilation, low perfusion could be caused by pulmonary emboli, SLE, which we just see all over the place. Sarcoidosis, does anybody know what sarcoidosis is? It's in every episode of House MD. Yeah. So remember we talked about granulomas, how we're going to have white blood cells sort of forming around an infectious or inflammatory thing. Sarcoidosis is like widespread formation of those that would impact different organs. Sarcoidosis in the lungs, for example, would be granulomas in the lungs. But it can impact multiple systems. Lungs, lymph nodes, eyes, skin. That's what's in my notes anyway. It's a type of granuloma. Yeah. And of course, alveolar carcinoma, with your naming conventions, you know what that is. What is it? It's a cancer of what cells? Alveolar cells. Well played, cleric. Okay, let's move on. Acute respiratory failure, again, when you are in respiratory failure for whatever reason, you're going to have low partial pressure of oxygen, high partial pressure of carbon dioxide, and of course, that is going to kick you into acidosis. And again, we can have a failure of respiration, a failure of ventilation, or a combination of respiratory and ventilation. Now, again, in AMP2, I managed to, we talked about specifying the difference between respiration and ventilation. What's the difference between, in real medical terms, respiration versus ventilation? Go for it.
Respiration is actual air going into the lungs.
Nope. Yeah, you're backwards.
Ventilation is actual air going into the lungs.
Yep.
Respiration is the actual.
Yes, that's the one. Yeah, you just had it backwards. Ventilation is air going in and out. Respiration is gas exchange. Oxygen across the respiratory membrane, carbon dioxide across the respiratory membrane, right? So you could have a failure of ventilation. Maybe your respiratory diaphragm doesn't work or some other reason. Or you could have respiration. Maybe there's a problem with the respiratory membrane. And so here are some causes of respiratory failure. And again, we will see some of these disease states in a bit. CNS issues. Remember, you have respiratory control centers where? In brain. What part of brain? Well said. I know it's after an exam. So actually, you guys are doing great. You managed to say the word brain, so. The medulla oblongata and also the pons. You did. Well done. Yeah, so 2 levels of the brainstem are participating in respiratory control. So a conch to the head, absolutely, can change your respiratory rate and ability. Chest wall and diaphragm dysfunction, pulmonary parenchymal diseases, we'll get into those. Airway problems, we'll get into those. Clinical manifestations, hypoxemia, hypercapnia, headache, dyspnea, confusion, decreased level of consciousness, which is a word we're going to see a lot over the span of this quarter. What's a decreased level of consciousness? Does anybody want to tell me about decreased level of consciousness? A coma, a really, really low level of consciousness would be considered a coma. Does anybody remember the criteria that we base it on? Lethargy.
Yeah, you can't get them to like wake up and actually do anything,
response time, orientation,
yeah,
right? Can they answer your questions or not? Can they speak? Can they speak real words versus babbling, blinking, sitting up, muscle movements? Yeah, we'll go into Glasgow Coma Scale in our neuro, which is towards the end of the quarter. What's up? Hypercapnia is carbon dioxide level is increased. Cool. And we'll see some of these long-term cyanosis, nasal flaring, retractions. We'll see some of what that looks like. All right, got nothing for you there to add. What's a situation that would give you pulmonary hypertension that we already know about? Right, it's left-sided heart failure. Yes. It took me a second too. Left-sided heart failure would also give you pulmonary hypertension. So again, we're going to have high pulmonary circulation, but pressure is actually going to be, only about 25 millimeters of mercury. But over that, you've got pulmonary hypertension. Got nothing to add there. Okay. So we've already discussed thromboemboli, thrombus formation, embolus formation. A pulmonary venous thromboembolus means most likely from a DVT, deep vein thrombosis, but not necessarily. 90% in deep veins of the lower extremities. That thrombus can embolize. It's most likely to go through the right side of your heart and then to the pulmonary arteries. And now I'm going to pause and we're going to watch a surgery video of removing a nice saddle embolus from the pulmonary arteries. And it's a great video. We just watched the video Massive Pulmonary Embolus! By Eric Beyer. And that showed the woman had a history. She'd fractured her leg and her leg was casted. So she had immobility. She'd had damage probably to the blood vessel wall. And as we already know about thrombus formation, those are going to be predisposing factors to having an embolus in a deep vein like that. It doesn't have to be a blood clot in order to embolize. There are other sources of emboli, such as fat, amniotic fluid, air emboli. Tumors can embolize foreign bodies. Septic, and again, exudate would be the embolus there, and parasites can also cause blockages like that. So again, the predisposing factors for thromboemboli formation: venous stasis, sluggish blood flow, hypercoagulability, and damage to the tunica intima of the blood vessel, right? That's kind of what that last patient had the perfect storm of. In her case, again, it was a direct trauma. Exercise can also help push those things along, although there's kind of an issue there of like maybe long-term exercise is going to be protective, but if you suddenly get up from a sedentary lifestyle and you've got thoughts already, starting to exercise may be dangerous. That's why at the start of every exercise video of your life, it's going to say consult a physician before starting this or any exercise regimen. Muscle action, remember, veins are acting based on the skeletal muscle pump and one-way valves. And then sudden changes in blood flow going from active to sedentary, sedentary to active, or any other changes in blood flow, which there could be many. Pulmonary malignancies, there's a variety of cell types within the lungs that you should already be familiar with. Some of those naming conventions don't really work as well with our 4 major types of lung cancer. Large cell carcinoma tends to develop in the periphery of the lungs. Small cell carcinoma tends to be central bronchial region. Squamous cell carcinoma tends to be in the hilar region. What do I mean by hilar region? What's the hilum? Nope. Hilum. What's a hilum? What? What did you say? Say it again. There's lots of hilums. Hilum? Lots of organs have a hilum. Lung has a hilum. Your liver has a hilum. Your spleen has a hilum. Yeah, all the blood vessels are coming and going, or any other tubes that are coming and going into that structure, right? With your liver, there's also lymphatics. With your spleen, it's all blood vessels. With your kidney, you've also got your renal pelvis and ureter, the renal hilum. So that's just an entry and exit point for blood vessels and any other series of tubes that you need. Fortunately, a lot of lung cancers can be asymptomatic until they're quite advanced. And the clinical manifestations will be based on the type and location of the tumor. For some reason, when I was originally doing this lecture, preparing it, looking into this content to be a better pathophysiology instructor, I looked up pulmonary malignancies and I still found a lot of misinformation about the source of pulmonary malignancies. There are still conspiracy theorists out there trying to say that there's no connection between smoking and lung cancer, which I thought was very weird, and I agree. So if there's still any confusion about that whatsoever, pretty much all small cell carcinomas, squamous cell carcinomas, and large cell carcinomas are going to be sourced from smokers. The biggest chunk out of this that's not from smoking is from adenocarcinomas. And then again, with these statistics, we're still not addressing secondhand smoke and things like that. So really, lung cancer equals your smoker for most people, the vast majority. There's no question about it, it's not up for debate. Not that anybody's ever tried to debate me in here, but again, it's very much one of those things, you go to Dr. Google and there's a lot of misinformation. Yeah. We'll talk about asbestosis. Yeah. Yeah. All right. Did she have any family smokers though? There you go. Wonder how that happened. Okay. Obstructive pulmonary disorders. Now again, this is a category, broad category of obstructive pulmonary disorders. That means there's an obstruction. That obstruction doesn't necessarily have to be your kid inhaled a button. That obstruction could also be mucus. It could be narrowing of the lumen. It could be any number of things. So asthma is a type of obstructive pulmonary condition. There's multiple types of asthma, and there's going to be histological changes seen in asthma, and those are 2 of your main learning objectives for asthma. So first of all, there's 2 types of asthma, intrinsic and extrinsic. There's intrinsic, which is going to be non-allergic adult onset, and extrinsic, which is going to be allergic pediatric onset. We're actually going to see some other subtypes, some exercise-induced asthma, for example. So extrinsic means something from the inside. Some allergen is irritating the bronchial walls. The airway lumen is irritated. And the good news there is that if we can treat the allergen, then we can treat the obstruction, or we can at least keep it from progressing horribly. Which means with intrinsic, which is non-allergic, the mechanism is a little more poorly understood. We can't find an outside source for it. then there's nothing you can do environmentally to control that. So that's kind of bad news, actually.
So is that non-treatable then?
I'm not entirely sure about the treatment protocols for it. What's
For
that?
the intrinsic?
Hmm? So what's their treatment protocol, if you don't mind sharing?
No, it's fine. They have me on
Singular?
corticosteroids.
Corticosteroids?
I had 2 steroid packs, and every time I have a coffee, I put down another one.
Steroid packs? Okay.
And then they also have a
Rescue albuterol inhaler? Okay. I'm putting it on the recording. I hope you don't mind. I didn't say your name. So that's good to know about, again, those were treatment protocols for sudden development of intrinsic adult asthma, which I think was interesting. Okay, again, extrinsic is about a third to a half of asthma cases. As this is an allergen, you are going to see that IgE antibody. Yep, it's coming back. It never leaves. And again, we can do some allergen-specific immunotherapy. We can do environmental control, get yourself some air filters, and so on and so forth. I'll finish up asthma, then we'll go on our break. Again, asthma develops in middle age, or not middle age, you're not middle age, with less favorable prognosis, no history of allergies. There may be a contribution from respiratory infections or psychological factors, being in quarter 4 and being stressed out. And again, we are not going to be helped by immunotherapy or environmental control. So I'm going to go ahead and stop the recording here for your break.